I'm Dr. De Leon. I'm a physical medicine rehabilitation specialist. I started out as a combat medic. In my career, became an emergency medical technician in New York City. Eventually became a doctor and became an EMT course director for several years at Fort Campbell. And so I've been teaching medics and medical students, primary care residents, nurse practitioners, and physician residents over the years. So I'm providing a series of classes. These early ones are all on vital signs. I'm going to move into physical exams in the future. So keep looking for my videos and subscribe. All right, so I'm going to become famous. All right, today we're doing blood pressure. And so the first question we're trying to answer is, what's this blood pressure? All right, what is the meaning of it? How do we use it clinically? So what is the purpose of blood pressure? Why does blood pressure exist? All right. Well, pressure is designed to push something, right? Whether I'm putting pressure on a wall or putting pressure on a fluid, it's trying to move the fluid. And fluid's going to flow down a pressure gradient. So as the pressure is highest in the aorta, it's going to drop as it goes into the arteries, into the arterioles, into the capillaries, and keep going downhill pressure-wise into the venules, into the veins, into the vena cavas, back to the heart. So that whole time pressure is going downhill in a pressure gradient, driving it. So the purpose of blood pressure is to drive perfusion, to push that blood through the circulation until it gets back to the heart, where the heart can pick up the pressure and elevate it again and drive it back down. All right, so the purpose of blood pressure is to drive perfusion. So what's the most sensitive organ in the body to continuous perfusion? All right, this has come up several times and will always keep coming up. What's the most sensitive organ? The first organ is going to know you don't have a good blood pressure. All right, perfusion is not happening. Well, as the example I've used before, we've all squatted down, we've done some work on something, we're doing something down here, playing with the kids, working on something, and we go to get up, and the blood pools in our legs as our veins don't constrict with getting up. We have decreased blood flow to the heart. The heart then squeezes an empty chamber for one heartbeat, less blood out, less blood pressure. And so the brain is going to know, hey, wait, there's a problem here. And how quickly does the brain know? Instantaneous. So if there's a problem with your blood pressure, the brain's going to instantaneously know, I don't have an adequate blood pressure driving the perfusion, and it's going to tell you. So in someone with a symptomatic blood pressure problem, low blood pressure, they're going to have altered mental status, loss of consciousness, a sense of not feeling well, lightheadedness. They're going to have symptoms. So in someone whose blood pressure is not pushing perfusion, the brain's going to tell us. So standing here, as I stand here, do I have an adequate blood pressure driving perfusion? Well, I have a normal mental status, so clearly I do. We don't know what my blood pressure is, but we know it's enough to drive perfusion. So if we measured it, all right, and it was low, you go, okay, and we'll get into interpreting low versus high blood pressure in a moment. First is to know what creates it. All right, so we do a blood pressure, we put a tourniquet on your arm, we blow it up until it cuts off all blood supply. We've created a tourniquet. And we put a stethoscope over an artery, and do we hear anything? No, we got a tourniquet on, no blood's going. So we're not going to hear anything. Then as we let the pressure go down, and we're going to assume for the moment that our pressure is going to be, actually let me use brown to create my graph. We're going to assume 80, 120. That is going to be our blood pressure. All right, made up a number. So as we let the cuff down, the cuff is up here, and well, that's not right. Let's see, orange. And if the cuff is up here at 150, the pressure in the cuff is greater than the pressure in the artery, And so we don't hear anything. But as we let that cuff down, and we get to 122, but 122 is still greater than the pressure of 120 over 80, and we'll figure out why we have two numbers here in a moment. All right, as we get down to 122, we still are greater. Then we get to 121, then we get to 120.9, 120.1. Finally, we get to 119.9. And what we find is that this blood pressure is actually a wave. All right, and we'll define how we figure out this wave and what that means in a moment. But at that instant we hit 119, there is a very brief period where the pressure in the artery is greater than the pressure in the cuff, pushes the cuff open, and blood squirts through. And we suddenly hear blood squirting through. And when we hear that, we go, well, what's the closest number? We can't, with our sphygmomanometer, fancy word, BP cuff, we can't tell 119.9, but we can say, oh, that's 120. That's right around 120. When I was above 120, I couldn't hear anything, but I hit 120, and suddenly I started hearing something. So I put down my first number, systolic. That's the top number. All right, we'll get into who creates it in a moment. First, we got to understand it. So we hit 119, and for a brief instant, the pressure in the artery is greater than the pressure in the cuff. Cuff opens, blood squirts through, we hear it, we mark it. We keep lowering the pressure. We're at 100. There's a period of time when the pressure in the artery is greater than the pressure in the cuff, and blood is squirting through. There's a period of time when the pressure in the cuff is greater than the artery, and the cuff closes down on the artery. All right, and we hear the little squirts of blood, so we keep saying, okay, well, I'm still hearing something. And then we get to 81, and we're still hearing something, and then we get to 79. And suddenly we stop hearing anything. And we go, okay, I didn't hear anything, that's my diastolic. So the last thing I heard was 80, so I got my diastolic. But why did we stop hearing anything? We said we didn't hear anything up here, no noise. Up here, because we got a tourniquet. Hope I spoke that correctly for all you grammar police. All right, I got a tourniquet going on, so no blood is flowing, so I don't hear anything. Got it. Down here, I've got no noise, but blood is flowing. So why don't I hear anything if blood is flowing? We said here, when I crossed the line, I got a period of time when blood was squirting through, and I heard that blood squirt through. And as long as I'm between these two, I'm hearing the blood squirt through. So why am I not hearing anything here? And that goes to laminar flow. All right? You don't need to remember the word laminar flow. Not important, but the concept is. When a fluid flows perfectly through a tube, it makes no noise. When a fluid is turbulent through a tube, it makes noise. So, when I'm between 120 and 80, I have a period of time when the cuff is not as strong as the artery opens and squirts blood, and a period of time when the cuff is stronger than the artery and the artery is closed. So as long as I'm between 120 and 80 in this example, the artery is doing this with every heartbeat. And because it's doing that, blood is bouncing through past this obstruction, and it's making noise. So I can, anytime you have any kind of obstruction, you can get that turbulent flow and we can hear it. So if you have a plaque in your carotid artery, I can put a stethoscope over your artery and I can hear pew, 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 pew. The same sound I hear when I hear here. Except I have a partial obstruction. Blood's getting through, but it's turbulent as it bounces across the plaque, makes noise, and in the case of an artery, we call that a bruit. And we go, wow, you got a partial obstruction there. If it was full obstruction, no flow, or a significant obstruction, I might not hear anything. If it's got an 80-90% occlusion, I might not hear anything. But if it's a 30-40% occlusion, I should hear a bruit. So I can listen over any artery, and if I hear noise that shouldn't be there, I got to think, is there a partial obstruction? So, blood pressure is a wave of pressure. It is not a single continuous pressure. The question is, why is it a wave and who creates it? Why does it peak at the systolic? Why does it trough at the diastolic? Well, what is going on? Systole, when we say someone is asystolic, they're in asystole. What do we see on the EKG? We all know this. That tells us they're dead. Or their leads fell off. Check the patient, make sure they're dead before you make any decisions. All right? You don't want to be like that scene with Schwarzenegger and the guy and the pizza, and he does an Alka-Seltzer and fakes a seizure, and then he's in the clinic and he pulls off the pad. Eraser, I think it's a movie. And the medic's like, oh my God, he's dead. And the guy at the pad is like, what are you doing? Check your patient first before you go, clear. So don't do that. So the blood pressure is a wave of pressure. All right? And asystole means no systole. A without systole. Well, what is systole? Systole is the contraction phase of the heart. So that phase is occurring when the heart starts contracting. Oh, can't see that one. Let me see this one. And it ends when the heart is done contracting. So that's systolic. The systolic phase, or systole. Diastole is the phase where the heart is relaxing. And in the case, we are measuring pressure on the left side of the heart into the body, so through the aorta to the brachial arteries, things like that, femoral arteries, to the legs. We're not checking on the pulmonary side, we're checking on the left side. There are ways to check blood pressure on the heart, on the lung side, but again, it involves standing below the necks and putting wires and lines down into the lungs and stuff like that, and obviously we're not doing that routinely. That's for the ICU. But when we're checking systemic blood pressure, we're checking the arms, the legs for the blood pressure. All right, so we're checking the left side of the heart as it pushes pressure out into the body. So who's driving this pressure wave to increase that pressure? Well, what muscle is squeezing during systole? We said asystole is without systole, so we know the heart is doing nothing. So the heart is in charge of creating the systolic pressure. So when the left ventricle squeezes, it is creating that pressure that is driving that blood out of the heart, down the bloodstream, down to the body. But then the heart has to relax. And because pressure goes downhill, for the left ventricle to fill before the next heartbeat, the pressure drops to 4. So if we were measuring the pressure in the left atrioventricle, we would see this peak, and then we would see it drop all the way down to here between heartbeats if we were measuring inside the heart. So people going to PA school, nursing school, DOMD schools are going to learn that pressure wave all the way down in the left ventricle. We're not worried about that. All right, but the idea is the pressure in the left ventricle is dropping to 4 because it's got to be the lowest so it can fill from that venous side coming back from the lungs, and it has to be low because if it's high, it's going to push back against that and push blood back into the lungs. That's bad. We want it low so it can fill. And we got valves to keep the blood from the aorta and the arteries back filling into the heart. So during diastole, those valves are closed back into the heart so blood can't go backwards, and blood is filling from the veins on the pulmonary side into the left atria, into the left ventricle. So the pressure drops to 4. If the pressure in your arteries drop to 4 between heartbeats, you'd look something like this. I'm awake, I'm awake, I'm awake, I'm awake, but you'd pass out between every heartbeat because the brain would instantaneously know, I'm not getting blood, I want to pass out. This really sucks. The brain needs continuous blood flow because even an instant, one heartbeat without an adequate output, it's going to immediately tell you. So the systolic is created by the left ventricle. So if the left ventricle is now closed off to the system, what's keeping it from dropping lower than 80? Somebody's got to be keeping it, dropping it lower than 80. And it's not just a time thing where it doesn't have time to drop any low before the next heartbeat. It's actually actively kept from dropping lower. Well, the pressure is inside the arteries, and if you compare arterial walls to venous walls to capillary walls, the big difference is arterial walls are muscular. So the muscles in the arterial walls constrict and maintain the pressure from dropping lower than this. So who creates diastolic pressure? The arterial walls. They keep it from dropping lower. So the left ventricle creates the systolic blood pressure, the peak, and the arterial walls create the diastolic pressure, the trough. Your mean arterial pressure is a mathematical formula that says on the average it's in the middle somewhere, and you may see that term mean arterial pressure, which means it's somewhere between the two, and it's a mathematical formula. Like systolic was twice the diastolic divided by 3, I think is the formula. But I could be wrong on that. But either way, all right, what we're focusing on is systolic and diastolic. So now we know what a blood pressure is, why it exists to drive perfusion, what's the most sensitive organ. So how do we use that information? So in somebody who has a normal blood pressure, we're moving on to other reasons why they might have symptoms. In someone who has a low blood pressure, all right, we'll say systolic is low if it's below 110, and diastolic is low if it's below 60. So if you got blood pressures lower than that, you start saying, well, your blood pressure is a little low or a lot low. Is that a problem? Well, if the brain is awake, fine, thinking normal, who cares? What's the purpose of blood pressure? Drive perfusion. What's the most sensitive organ? The brain. If the brain says, I'm fine, you're fine. And in fact, when we look at spinal cord injury patients, you know, the classic paraplegia, tetraplegia, or quadriplegia, whatever term you want to use, I'll see blood pressures of 86 over 42, and that's a normal blood pressure for them. In fact, 120 over 80 is hypertension, and I got to give them drugs. I got to put them on hypertensive meds, because that's not normal for them. Now, for us standing around, classically, you run into somebody with a blood pressure of 86 over 42, I'm probably going into shock. But they live at those blood pressures. So a low blood pressure that is asymptomatic, nobody cares. You're clearly achieving mission. That's where they're living. For whatever reason, that's their blood pressure. They're achieving mission. If it's symptomatic, why is their blood pressure low? Is their tank empty because they're in hemorrhagic shock? Is their heart failing? They just had a heart attack, they're in cardiogenic shock. Did they get stung by a bee and their blood vessels expanded and they're in anaphylactic shock? But they got a problem and we better respond and fill the tank, cut off the bleeding, whatever we got to do, epi, Benadryl, whatever we have to do to keep this person alive, and you've got those criteria: hemorrhagic shock, the fluid of choice is blood. Because blood not only fills the tank, blood has clotting factors to stop the bleeding, and blood carries oxygen to the tissues. If you just give lactated ringers or normal saline to somebody in hemorrhagic shock, you've diluted their clotting factors and you've turned their oxygen carrying capacity into Kool-Aid. It doesn't carry oxygen, you still get tissue hypoxia. You may be filling the tank, but you're not solving the problem. We used Hextend for a while, then Hextend would dehydrate the tissues and pull fluid into the bloodstream as opposed to normal saline lactated ringers that would leak out of the blood vessels, so you needed twice or 3 times the amount of fluid for every liter of blood loss. You needed 3 liters of normal saline to fill the tank, because most of it would leak out. Hextend did the reverse, but again, you're still diluting clotting factors and you're reducing your oxygen carrying capacity, so blood is the answer. All right? In someone who has high blood pressure, the question we ask ourselves is, are they symptomatic? Are they acute chest pain? Are they acutely altered mental status? Are they having a stroke or heart attack in front of you? Are they hypertensive emergency? If they are asymptomatic, then it goes back and forth about hypertensive urgency and the need to drop that blood pressure, how quickly. We know hypertension, all right, untreated, even asymptomatic hypertension, untreated eventually leads to vascular disease down the road, heart attack, strokes, amputation, renal failure. Acutely, if they're not having any symptoms, all right, it's a debate over whether you should bring that blood pressure down or just start them on antihypertensive and see them back in 2 weeks and see how they're doing with their blood pressure, all right? And I've seen it over the years change, where if you're greater than 180 or greater than 200, then we call it hypertensive urgency, even if you're asymptomatic, and we say, okay, we got to drop that and bring you down to 150 at least, or whatever, the sublingual nifedipine and all that kind of stuff that I've seen done over the years, and this seems to change. So I won't get into what you should do, because that'll be under your medical protocols, all right? But if you see somebody who's hypertensive, asymptomatic, at the medic level, EMT level, get them to a doc. You got hypertension. Let them worry about whether they're going to start meds or not, whether they're going to acutely drop it or not. All right? But you should not let that person walk away. You've taken a high blood pressure. All right? One of the things you need to also think about, little caveat, is a thing called coarctation of the aorta. I'll spend just a second just because it's a little fun in terms of knowledge base. But here's your aorta coming out of your heart. All right? Vessels, whatever, coming off the aorta. There is a condition where there is a obstruction in this area, and to drive normal perfusion to the kidneys and to the rest of the body, this obstruction is blocking it, so you got to get pretty high on this side. So this one might have a high BP, and this might have a normal BP. So the standard of care is the first, because we're trying to get what is the heart seeing, what stress is the heart seeing. So the closest we can get to the heart is to do blood pressure in the right arm. The right arm is closer to the heart than the left arm. Not distance-wise, but blood flow-wise. In terms of the first branch off the aorta is headed to the right arm. So we check blood pressure in the right arm. If it is high in the right arm, and we've done a little wait, a few minutes, relax, whatever, and I recheck and it's still high, the standard should be check the blood pressure in the left arm, document both. If they should be fairly equivalent. If they're fairly equivalent, that means there's no obstruction in the aorta, no coarctation. If they are significantly different, you're getting 182 over 104, and you're getting 136 over 88. They are significantly different. And you convince yourself it's not technical error, whatever, you have just diagnosed coarctation of the aorta. Person needs a referral, and as you're referring him to the doctor, because you're sending him for high blood pressure anyway, note that you have a normal blood pressure in the left arm compared to the right, which means they need an ultrasound of their heart and aorta or a CT of their chest to look for this, and then sent to a cardiothoracic surgeon to fix it before that high stress causes a heart attack. But if you're always checking in the left arm, you run the potential of missing this very rare condition. So the standard of care is check pressure in the right arm. When it's abnormal, check the left. All right? So in summary, what we've done is we've talked about what blood pressure is, all right, what it does, how to understand the systolic and diastolic, who's creating it, so that we can understand then how to interpret the numbers when we get them in clinic. All right, understand the difference between high blood pressure, low blood pressure, and treatment reactions to both. All right, thank you very much. Continue to subscribe, and I'll continue to teach out here.